Hello, everybody. Welcome to Grand Rounds on March 15th. Can't tell you how happy I am to have with us Dr. Satoko Kanahara, who I had the pleasure of working with at Community Healthcare Network, where she is now the medical director of the South Bronx Health Center, and really one of the people instrumental in building up this refugee program that she is going to be speaking about today. She completed her medical school at Cleveland Clinic and did a joint medicine and pediatrics residency at Baylor and has been at CHN ever since. And we are thrilled to have her with us. Take it away, Dr. Kanahara.
Thank you so much for the introduction, Dr. Weissman, and thank you all for having me here today. And I'm very excited to be able to talk to you about refugee healthcare, which is one of the things I love doing as part of my primary care practice. So let me just share my screen. Here we go. Okay, so today my talk is entitled Refugee Healthcare in New York City. And there we go. All right, the objective for today's talk is to just familiarize all of you with concept of who refugees are, the difference between refugees and asylum seekers, asylees, and undocumented immigrants. So you have some familiarity with those terminologies, and to talk briefly about what is involved in refugee health screening. And then at the end, I'm going to close with a case that you might encounter when you're treating an immigrant population. So just a little briefly my background. So, Dr. Weissman has nicely introduced me about, my educational background. But prior to coming to college, I actually lived in multiple countries. I grew up living in the US, Japan, Turkey, United Arab Emirates, and India. So I just had a very international background growing up. And so naturally, I was really interested in working in like a diverse population. And in particular, I was interested in working in primary care. So I joined the Community Healthcare Network in 2015. It's a federally qualified health center. We have 12 locations throughout the city, and I work in the South Bronx. And just to give you an idea of what kind of populations we work with, it probably is similar to who you see in your residency clinics and some outpatient practices, but we serve a predominantly Hispanic and Black population. Most of our patients are Medicaid, as they have Medicaid as their health insurance, and quite a bit of them are uninsured, and a good number of them live below poverty level. And just to quickly remind you, poverty level is a federally set poverty guideline, and for a family of 4, that means that a lot of my patients are getting have total household income of say 26,000 or less for a family of 4. So the resources that's available to people in a lot of our communities in New York is very limited. And the reason I'm talking about some of these things is just to kind of give you a background that, while I'm talking specifically about refugee health, by working in New York City, all of us are really working with a very diverse populations who come from different areas. And a lot of what we talk about for refugees apply to patients we see every day working and practicing in New York City. So this is a map of which households have foreign-born population compiled by New York City. As you can see, most of Queens and Brooklyn, for example, a lot of the people are foreign-born and have come to New York and the United States as an immigrant. So in New York City, these are top 10 countries where people come from. So Dominican Republic, China, Mexico being a top, and then followed by these other countries. So we do really practice in a very cosmopolitan, diverse population. And just another statistic of New York City household, only 38% of the households contain US-born only members, and a majority of the households in New York City have mixed status or have some people with green card status or other status. Now we're moving into talking a little bit about refugee in particular. So this is data from UNHCR, and as you can see, we have 80 million people who are forcibly displaced worldwide due to conflicts. And the bar line at the bottom, you can see that, really the numbers picked up around 2013 and has been in a rapid incline, has seen a rapid increase in the last few years. And a lot of it has to do with politics. So, we might be sort of caught up in the medicine things, but it's important to sort of understand a political background. And I'm always trying to educate myself about what is going on. But 68% of all the refugees and people who are displaced come from these just 5 countries: Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. And these, a lot of the reasons for those numbers is because of their internal conflict and social political backgrounds in those locations. So where do the refugees go to? So the majority of the refugees actually migrate to neighboring countries. As you can see, a lot of people from Syria go to Turkey. Germany was a bit of an exception. They really opened their gates to like helping out the Syrian refugees. A lot of them did resettle in Germany, but for the most part, people from Afghanistan went to Pakistan, South Sudan, Uganda. A lot of Venezuelans went to Colombia. So they tend to migrate to places that are close to their country of origin. And political influence, as I said, is a huge factor in who comes into the United States. So for example, 2020, we're expecting to see 15,000 refugees per year, which is the lowest number of refugees we're accepting in a recent history. Whereas President Biden has pledged to admit 125,000 refugees, and that will be determined in October when he passes the law for 2021. So the number of refugees are set by the president's setting how many people can come in. And just to give you idea of the trends. So in the 1980s, when the refugee settlement program started, we had a tremendously high number of refugees coming in, has sort of stabilized. And since the Trump administration's number has fallen down somewhat, and we are expecting to see some rise in the Biden administration. So our programs, we actually saw nationally a few programs for refugee screening programs shut down because they were only doing refugee care and they just weren't seeing anybody coming through. So it is heavily influenced by domestic and international policies. And this is the first bar graph on the left is what I showed you earlier, where the refugees are coming from, where a lot of the people are displaced. And on the right is top countries that the U.S. accepts as refugees. So you see that they're not necessarily the same. We are accepting a lot of people from Guatemala, El Salvador, Venezuela, Mexico. So people from Central America and South America, and whereas the refugees in the world, a lot of them are coming from other parts of the world. And then we have, Chinese immigrants as well. And looking at the divide between refugees and asylum seekers, I'll talk a little bit more about the difference in a bit, but just so you can get some sense, in 2010, most of our the refugees and asylees coming into the country were refugees. But in 2020, the number of asylum seekers has way surpassed the number of refugees we have in the country. So we do see some trends and differences in what type of immigrants and refugees asylums are coming into the country. All right, and then when they come into the United States, where do they go? So the top 10 states where they resettle are Texas. These 10 states, and the top ones being Texas, Washington, Ohio. New York comes in right here. So we do have a good number of, we do rank 5th in the number of refugees that resettle within the United States. However, most of the people who come into to New York, the refugees tend to settle outside of New York City. So New York City only makes up about 15%, and a lot of them resettle in Albany, Buffalo, Rochester. There are a lot of refugee communities in upstate, and a lot of times the decision of where they settle depends on if there is an existing community from that country that's already there, and also cost of living, if they have families, relatives, those sort of things. And just because New York City is a little expensive compared to the upstate locations, we don't tend to get as many people coming into the city. And those who do come tend to have family members or somebody they already know in the New York City, so they're joining them here. And then this is specific to New York. We have a lot of refugees coming from Afghanistan, Burma, Ukraine, Congo. And a lot of the people coming from Afghanistan, they have a visa called special immigrant visas, where usually some member of the family has worked as a translator or interpreter in Afghanistan for the US military. So then they get a special immigration visa to come into the United States, and they get treated similarly to the refugees. So what is a refugee? So the official definition of a refugee as defined by the United Nations is a person who has fled their home country and cannot return because of well-founded fear of persecution based on race, religion, nationality, membership in a particular social group, or political opinion. And the refugee person has to, somebody who is seeking refugee has to prove that they have this well-founded persecution based on these bases. And this process can actually take a very long time. So right now, the average is about 18, average time it takes for the processing of the refugee, getting the refugee status is about 18 months to 3 years. It includes getting approved by the UN. They have to have multiple interviews, approvals. So there's a lot of different steps that the people have to go through in the middle of turmoil and moving from between different places. And once they go through all the hoops, they are allowed to come into the United States and resettle as a refugee. So what is the difference between a refugee and an asylum seeker? So they're similar in that the reason why they're coming to the United States is fleeing persecution and in the need of a protection in another country. The main difference is that asylum seekers are already at the border of the United States or whichever country they're seeking asylum, or inside of that country. So in this case of the United States, inside the United States or at the border applying for protection or asylum. Refugees are granted refugee status prior to the arrival to the United States. They have all the paperwork done. They have had the screening, and then by the time they come to the United States, they have legal status. Whereas asylum seekers don't have legal status, and they are trying to get legal status at the border, or they're already inside of the country trying to get the legal status. So asylum seekers actually have very limited resources before they are granted legal status. So they're really undocumented. A lot of them actually come as an undocumented immigrant in the United States, and they're just in the process of getting legal status based on the persecution they faced in the country. And when they enter the United States, they have to apply for asylum within a year of arrival to the United States. And sometimes there's social and language barriers. They have to find lawyers. And so it could be a very difficult process for people who come into the United States to seek for asylum, even if they're escaping legitimate persecution and difficulties in their country. And if they get denied asylum, asylum seekers can get deported outside of the United States back to their country. And so the asylum seekers are actually very vulnerable, whereas the refugee patients that we see in our clinic already have gone through the process. And by the time they see us, they have no fear of deportation. They can legally stay in the United States. Once an asylum seeker actually is granted an asylee status, so once asylum is granted, they go from asylum seeker to an asylee. And once they're granted asylum, once they become an asylee, they really have similar legal rights as a refugee. They can work, they can remain in the United States, they can get green card after a year, they can even apply to become a US citizen after 4 years of being granted an asylum status. So just kind of a recap. So for refugees, they're fleeing the country because of conflict. They obtain the paperwork to come into the United States beforehand. And then by the time they come to the US, they have all the legal work and they can settle in the United States. Whereas asylum seekers, they're at the border or in the United States and they don't have paperwork and the legal status yet, but they get that either at the border or inside the United States. And once they are granted, they can become asylees and have the legal protection. If they are not granted the status, they might get deported or remain in the country as undocumented immigrant. So we have a huge increase in a number of asylees coming from Central America. Probably the most famous one is the Migrant Caravan back in 2018. It started out in Honduras and thousands of people en masse headed towards the United States. And similar things are happening even now. I think as recent as January, there was another, they were talking about caravan coming up from Central America. And a lot of these people don't have legal status and in the United States, so they are asylees trying to obtain access, to be granted asylum so they can enter the United States. However, it is very difficult, and the majority of the people are turned away at the border, either to go to immigration centers or be turned back to Mexico to wait for their court hearings. So undocumented immigrants are, they come to the United States for whatever reason. It doesn't have to be a conflict, actually. It could be economic, opportunities, whatever reasons, but they come to the United States without a legal status, or they overstay a visa that granted them entry in the beginning, and they stay in the country, but they don't have legal status. So asylees who are rejected from asylum might actually fall into the category, or some of those immigrants who qualify for asylum may apply for asylum if they've only been in the United States within the year and they have reasons that they are being persecuted in their home country. So going back to healthcare things, since we're all clinicians, right? So healthcare coverage, when you compare people's healthcare insurance coverage in New York by immigration status, you can see that the undocumented immigrants have the lowest healthcare coverage. New York definitely has better insurance coverage than a lot of places in the country, but most of the undocumented immigrants are not eligible for Medicaid or other health insurance. Some of them who are eligible might be eligible through emergency Medicaid or pregnancy, or there's program called ADAP that covers patients with HIV. So there are some special programs, but a lot of them do not have health insurance. And asylum seekers will likely fall in this category of undocumented immigrants and having low health insurance, whereas refugees and asylees, once they're granted, they probably fall in this green card holders and other status where they can have benefits of health insurance. Oops, sorry. So a little bit about our program at the Community Healthcare Network, where I work. So we started a refugee health program back in 2016. So what we do is we work with refugee resettlement agencies. These are nonprofit organizations that work with the government to help new refugee families or refugees settle into the United States. So they greet them at the airport and they help them, find housing. They help them, get their medical care. So the resettlement agencies, when they know they have a family coming in, they contact us and then we refer them. And then we put them in our schedule for the refugee health screenings. So all the refugees, when they come into the clinic, they do need health screening conducted, preferably within the first 30 days and by the latest 90 days. And so we conduct the initial screening and then we try to transition them into primary care. So refugee patients have all had pre-departure health screening prior to coming into the United States. It's one of the requirements for their refugee immigration. And once they come into the United States, they're supposed to get medical screening, which we provide. And what happens in the actual visits is very clearly laid out by the CDC. It's step-by-step, very detailed what we need to do. So I'm not going to go through every single detail, but just to give you an idea, the overseas medical examination, which they do prior to coming to the United States, that is done by US accredited physicians. And they identify things called Class A conditions. So basically, these are things that make refugees inadmissible to the United States. If they have these conditions, they cannot enter the United States at that time. So these include active TB, untreated gonorrhea, syphilis, Hansen's disease, which is leprosy. If they're untreated and infectious, they can't come in. Other infectious diseases that require quarantine, serious mental disorders with harmful behavior, serious substance abuse and dependence. Vaccine declination is not listed on all of them, but I have seen that in some of the documentation if there is concern that they could have infectious disease due to declining vaccinations. And Class B conditions, so these are not as severe as Class A conditions, but does need follow-up. So basically, if you have like latent TB, or if they had infections like leprosy or Hansen's disease, syphilis, but they have been treated, if they have mental health disorder, but it's milder, or if they have substance abuse that's in remission, those are considered Class B conditions. So they are still allowed to come into the United States, but they may need follow-up and further medical care. So what's not routinely checked, interestingly, was COVID-19 was not routinely checked for refugee patients, although one of the criteria was, that I talked about was infectious disease that require quarantine, but they didn't specify COVID-19. So when they enter the United States, they would just have to follow the rules and quarantine rules of each state. And they don't also routinely check for HIV either. This was 2010. There was a decision to stop checking refugee patients for HIV. And if they are coming from Africa, all of the refugees will receive treatment for malaria. And Asia, Africa, Middle East, Latin America, so a lot of the places that have high prevalence of sexually transmitted ailments, they will receive albendazole prior to coming to the United States. And strongyloides, also in these areas, if the refugee patients are coming from these areas, they're supposed to get ivermectin as a presumptive treatment for strongyloides due to higher prevalence of these diseases. And schistosomiasis if the patient is coming from sub-Saharan Africa. So when they come to your clinic, ideally they should have all those documentations with them. They don't always, unfortunately. Sometimes they forget or it gets lost, but presumably everybody has gone through all these treatments if they're coming through as a refugee. So who is not getting any presumptive treatment? So I listed a lot of areas, but refugees coming from Europe are not one of them. So the reason is because the rates are lower for these infections, but it's important to know who is screened for what and who is given what medications and who's not. We do see quite a lot of Ukrainian refugees from Europe due to religious persecution. So that's something to consider when you're seeing the patients. And as part of the domestic health screening, basically we're doing a full complete H&P and making sure, trying to catch the health maintenance things, helping them transition to primary care. And we regularly just screen for conditions, anemia, just making sure their kidney, liver functions are okay, hepatitis screening, HIV screening, TB screening. We also do O1P and strongyloides IgG to check for parasites and infections. And for those from sub-Saharan Africa, if they don't have documentation of treatment for schistosomiasis, we do an IgG for schistosomiasis. And it's also very important to screen for trauma. So a lot of these patients have gone through years of transition, and they might have left their home long time ago and have gone through a lot of different rigorous processes. They might have seen very traumatic scenes and experiences in their home country. So we do try to capture those experiences and screen for depression, anxiety, mental health disorders specific to trauma. And we use regular ones like PHQ-2, PHQ-9, but in addition, in our organization, we use a screening tool called the Refugee Health Screener 15 or RHS 15, which has been specifically validated for refugee population. Another popular one is a Harvard Trauma Questionnaire. So most of the places that see refugee patients have some kind of screening for trauma that says for mental health needs. So this is just kind of some of the questions that people ask. We ask people for RHS 15 as the refugee health screening. So similar to like other screenings, just looking for somatic pains like bone joint diseases, feeling down. So we try to go through these questions to identify patients who might need mental health care. And trauma can manifest, anywhere from just sadness, depression, pain, insomnia, distrust, a strained relationship. So there's different ways it could manifest. And one thing that we try to educate our providers across the network in our organization is trauma-informed care, which is how to be mindful of the pervasive nature of trauma for our patients and promote an environment of healing and recovery and avoid practices that may inadvertently cause re-traumatization. And I think that's a really, really important concept that, through our visits with our patients, we may cause further trauma to whatever they are already experiencing inadvertently. So if we are not being careful about their past experiences and how they might be reacting because of their past trauma, we could re-traumatize somebody just through going through what we think is a regular medical exam and medical process. So just a little bit of what kind of things can be re-traumatizing. So this is actually a slide from University of Buffalo. They have a whole center for trauma-informed care, and we've actually had lectures given to our providers from them, and it's very, very informative, and not just for refugees, but applied to veterans, who are coming back from war zones and other types of trauma. But just looking at our healthcare systems and realizing that these things, there are things that could re-traumatize somebody, such as people not feeling like they're seen as a person. They're just not being heard. They have to do things that they don't want to do. So we might just think it could be just as simple as a blood draw, or like having somebody sit in a certain location. We might just think, well, this is just what we do, but it could be re-traumatizing to people. So I think the important thing, we never know what's going to trigger somebody, but just being mindful and reading the body languages and giving options, and giving options of what to do when the patients seem uncomfortable, rather than just sticking to the rules and being rigid. I think that's very important, treating this population. So this is also from University of Buffalo, and they published on this, but what kind of things can we do as providers to be mindful of trauma? So giving choices, empowerment, collaboration. So it could be that, maybe they don't want to do a genital exam the first time you see them, or maybe they don't want to talk about trauma and they don't want to answer those trauma screening questions. There could be different things. And most of our patients are very willing to cooperate with our exam, and very nice, and they're very appreciative, and we love working with them. But if there are patients who just don't want to go through all this, I have heard people who say like, well, I've done these physical exams just a couple weeks ago back in my country, why are you doing this again? So just kind of explaining things and giving them some options. Maybe they need to come back and complete the rest of the exam or part of the test at another time. I think that can be helpful in a population that has gone through a lot of trauma. So at this point, I want to just move on to shift gears a little bit and go through a case. This is actually a case not directly from a refugee patient, but a patient that I saw in a clinic. But this is, as I said, a lot of our patients are coming from outside the country, and a lot of the disease conditions overlap. So this is a case of a 74-year-old female with no significant past medical history, not really taking any medications. Came in for routine labs, a routine physical, and found to have a new onset microcytic anemia. And when I asked her some questions, like she does endorse some mild dyspnea and exertion and fatigue, but nothing so severe. If I asked her, she would admit to it, but she didn't come in complaining of those things. No melena, no hematochezia. And yeah, as I said, she doesn't really have much history of any medication use or allergies. She is from Puerto Rico and moved to the Bronx 30 years ago. And she does travel back to Puerto Rico a few times a year to visit family who's still there. She doesn't have any history of colon cancer or any significant family histories to speak of. And she reports having had a normal colonoscopy 5 years ago. And on exam, she looks pretty healthy, no particular findings. So just to go through the labs, so a year ago, her hemoglobin was 12.6, and now it's 9.2. The MCV is low, the ferritin is low. And then of note, there's also some eosinophilia they're present from before, but it wasn't really worked up. So she does have iron deficiency and eosinophilia on presentation. So we started her on just iron supplements with the presumptive iron deficiency. Referred her for colonoscopy, EGD, to look for source of bleeding. We also did some stool O&P and strongyloides IgG. And the stool O&P came back normal. The strongyloides IgG came back positive. So she did a colonoscopy, and they found an eosinophilic colitis, and she was treated for ivermectin for strongyloides, and anemia eosinophilia resolved, and the repeat colonoscopy showed resolution of the eosinophilic colitis. So just a word about strongyloides, just because this is something that you probably will see in your clinic and your patient populations. It is present at a higher rate among the refugees. 25 to 46% of the refugees may have strongyloides. In the United States population who are not recent immigrants, the positive rate for the IgG is about 0 to 6%, depending on which data you look at. The transmission is larva penetrating into the skin. So if you're walking barefoot, you have a contact with sewage, human waste, farming, coal mining. So people more from the countryside might be prone to getting strongyloides. And it can persist years without any symptoms or any abnormalities, and one day just show up. So the most common clinical presentation, or how it gets discovered, is eosinophilia. So strongyloides, as I said, penetrates the skin and goes through this whole cycle inside of the body. It grows up into an adult parasite inside of the intestines, and the female parasites lays eggs, and then the little larvae can go into large intestines. It could go to different organs. So it penetrates through different layers and can spread to different parts, could get into the lungs. So it can get into different organs. And hyperinfection syndrome, you may see this with patients who are on transplant service, or any steroid use can trigger strongyloides to become active. And it doesn't matter how much or how long they're on the steroids, even the low dose have been seen to cause hyperinfection syndrome from strongyloides in the setting of immunosuppression or corticosteroid use. And the mortality can be quite high, more than 50% in some of the cases. So it is important to look for not miss strongyloides, especially if somebody's going to be on immunosuppression. So not all parasites cause eosinophilia. I know that's something that people always think, oh, eosinophilia must be parasites, but most of the parasites that cause eosinophilia are the parasites that move between organs. So as they're going through lumen and passing through the layers, that's when you get the eosinophilic reaction. Whereas things like Giardia, it mostly stays in the gut. It doesn't really get to other organs. And so you don't typically see eosinophilia with Entamoeba, Giardia. And there could be other causes of eosinophilia, obviously, that we have to look for. And for example, in the case of strongyloides, you can't really, the sensitivity of finding it on OMP is very low. You might need as many as 6 samples of stool before you can see the strongyloides. So IgG is often used, and the titers tend to correlate with infection. So if they're treated, the titers tend to go down. And schistosoma as well, we tend to do IgG just because, again, it's hard to detect otherwise. So if this talk, if any of this is of interest to you, there are organizations. So the first 3, the International Rescue Committee, Highest Catholic Charities, these are all refugee resettlement agencies we work with, and they're major organizations that have been working for many years. And the refugee organizations have information about things that you can do to help. And also you can start a refugee medical assistance program by registering through the New York State, which is what we did for CHN. And really, they monitor us and audit us to make sure that we're following the protocols. But any U.S. Physician can serve as a refugee health screener and provide these services. So I'm ending a little early, but at the end, I just wanted to end with a quote and a picture. So this young man is actually from Afghanistan. I've gotten permission from his father to share the picture with all of you, but he came as a refugee. His father was working as a interpreter for the American U.S. Army in Afghanistan, so brought the whole family over. He didn't speak English. We saw them, like it was like a big family of 6. We saw them, and they sent me a picture later showing that he graduated from middle school. He's going into high school. So a lot of these families, they integrate into the society and they do really well. And it's really exciting to see, kids growing up here and getting education and, staying healthy. And the quote on the side is from Khaled Al-Hosseini, who's a doctor from Afghanistan who was working as an internal medicine physician and wrote a book called Kite Runner, which some of you have probably heard of. It's a very, very famous book, and quit doing medicine and is now a writer. But this is a quote from him saying, refugees are mothers, fathers, sisters, brothers, children with the same hopes and ambitions as us, except that a twist of fate has bound their lives to a global refugee crisis on an unprecedented scale. So with that, I'd like to end the talk, and I'm open to any questions or any suggestions. Thank you so much for having me.
Thanks so much, Satoko. I really appreciate it. So we'll open the floor and the chat for questions. Maybe, I think you hinted at this, but I just wanted you to summarize a little bit for those of us who are, seeing patients, but not like specifically seeing refugees. What are sort of the takeaway things, for those of us who have, you know, a pretty broad immigrant population, I guess we should be thinking about trauma-informed care, and maybe we should be thinking about broader infectious disease screenings than we already are. Is that sort of the big takeaway?
Sure. I think there are a couple, I mean, I didn't go into everything, but, you know, so infections definitely a big thing. We do, honestly, most of the infections that I come across in our population is just non-pathologic, you know, pathogens, intestinal pathogens. We see Giardia here and there, but nothing, you know, we haven't seen anything that was like out of control, anything crazy. One other thing I didn't talk about that we do screen sometimes is for lead exposure. We do that. So I'm a pediatrician as well. So we screen all the kids up to 16 for lead. And we did come across a few instances of high lead levels, and we screen the parents as well. So those things you might not see as much in the United States. We see more from people coming from outside of the United States. But I think, yeah, I think the major ones are probably GI. Malaria, I haven't really, we haven't had that many patients from Africa either. So that's probably why, but we haven't seen as much malaria or schistosomiasis. So it really depends on where the patients are coming from, and just having some idea of, you know, what infectious diseases might be more common in the area. The big one is probably the sub-Saharan Africa, because that's where schistosomiasis is, malaria is, and a couple other, you know, intestinal parasites.
Great. Dr. Berger.
Yeah, I just wanted to say thank you. Wonderful talk. I think that whether, because it's New York, whether you engage in specifically refugee health or not, we all take care of lots of people that are here, whether they consider themselves refugees, people who just happen to move here for different reasons, all sorts of stuff. And down here on the Lower East Side, we deal with a very large Caribbean population. And there are different, obviously, parasite or, you know, helminths and causes of eosinophilia. We can call them parasites, but I didn't want to insult the parasites. So, you know, we do see a lot of strongyloides here. And I think that you raised a lot of great points. I think one of the things, having been involved in these sorts of cases as well, just to add, not to steal your thunder, but we see it, and there have been great studies that show that we overdiagnose asthma because in the strongyloides, the life cycle, the sort of lawful, the infection of the lung with eosinophilia very rapidly gets transferred to the idea of asthma with eosinophilia. And we sometimes forget about these other causes of that. And I just wanted to say that. The other thing I would say is I would thank you for pointing out how terrible a test a stool OMP is. It really is not high sensitivity. We miss it. Your point to six stool studies being needed. I love that you highlighted strongyloides antibodies and other antibodies when possible. And more of these are coming online. So we should all do a great job following your lead of trying to educate ourselves about what is a better test than the old non-specific tests that populate textbooks because they were around when textbooks writers sort of learned about these things. So I wanted to thank you about that.
Thank you for the comment. Yeah, I agree. And I think there's a comment from Dahlia saying on the side that there's actually a clinic for victims of trafficking, I guess, with the family medicine program. So that's wonderful. I believe Elmhurst has a program like that as well. So there are definitely resources for patients who have severe mental health issues. So that is definitely something that, you know, we having the resources can be very helpful as well, because it could be beyond what we can provide in our primary care settings.
Other questions, thoughts? Satoko, did you want to talk about vaccines at all? I mean, do people come with, I guess they sort of get vaccines at their pre-travel physical, and then
They do, yeah, they do, but it's not always complete. Like they have, like, you know, MMR, Tdap, Hep B maybe. So it's actually more of an issue for kids, because the kids have to go to school and they have to show that they've had all their shots back in their country. Sometimes they come with, like, the hardest ones are the one that come with, like, you know, Arabic vaccine records, and their vaccine types are slightly different than ours. So, you know, like they would be like, like it's a vaccine with 5 things in it. And it's like, well, which 5 could that be? You know, that sort of thing. So just kind of a lot of Googling and searching things. But we do get away with, I mean, the official guideline is if you don't have the vaccine records, you need to restart and revaccinate the whole series. But since the New York State schools accept titers, I tend to do the titers. For most of the countries, if they've had some kind of medical care, they would have had measles. A lot of them have had varicella already. So I do check those. But definitely polio for kids, tetanus shots. If I don't have documentation, I do those. And yeah, so making and then a lot of them have Hep A. That's true. Hep B, Hep A, we screen for, as I said, and we do see some chronic Hep B. So we do pick those up here and there. But yes, definitely we have to go through the vaccines. They have paperwork, but it could be great, or it could be nothing, or it could be in another language. It's very variable.
Got it. Thanks. Dr. Steinberg just unmuted. Do you have a question?
I do. It's not totally related to medicine, but it's related to refugees and asylees. And I wonder if you know what kind of identification is available to asylees. Can they get a New York City ID? I'm just wondering, you know, the question about vaccination brought it up, and what's available to them?
I believe so. I don't know 100%, but I believe that in New York State or New York City at least, everybody can get like some kind of an ID, regardless of their immigration status. But a lot of other states are not as liberal, and you know, there's always been talks about what can they drive, can they not drive. So that's a constant, you know, battle. But New York State, I believe, they can get some kind of an identification. Although a lot of people fear being caught and just they don't want to register themselves.
Sure.
And with public charge, so public charge, as many of you know, public charge is basically if you use public services, it could interfere with your application for visa in the future. So if somebody is an asylum seeker, they may not want to take advantage of Medicaid or services that are available to them because they fear that it's going to be used against them when they apply for legal status. So a lot of even things like food stamps, and WIC, which is for babies and, you know, babies' milk and things like that. We do have patients that worry about receiving those services, although they don't have resources because of those things. So, you know, medicine is one part, but then there's a huge other social component that affects their well-being. So it is challenging. But New York State, other than compared to other places, I think is a little bit better.
Thank you.
Mm-hmm.
Other questions, thoughts? Nothing. Dr. Kanahara, always a pleasure to see you. Thank you so much.